During this lecture, we're going to go over bone physiology. So during the last part of the bones lecture, we went over the anatomy and the structure of the bone tissue. During this part, we're going to talk about the physiology of the bone. So as we talked about before, bone is a metabolically active organ. So the bone is constantly resynthesizing and reabsorbing itself, and it is responsible for its own maintenance. It is made up of connective tissues such as bone tissue, cartilage, and it is synthesizing itself and breaking itself down. It influences the physiology of the rest of the body, and in conjunction with the muscular system, it provides structure, and it is the organ for hematopoiesis and an immune organ as well. Now, it is also the organ for mineral storage and a physiologic organ for the nervous and the muscular system. Now, let's talk about the deposition of minerals. So when we talk about mineralization or crystallization, we're talking about the addition of calcium and phosphates to the ground substance of bone, along with collagen fibers. So when we talked about the osteogenic stem cells, they mature to form osteoblasts. Now, if you recall from the last lecture, the osteoblasts were the collagen-secreting cells. So they synthesize the collagen fibers, which absorb calcium and phosphate ions from the bloodstream and harden to form that hard ground substance. So in bone, the ground substance has to become hardened and tough. However, you do not want other tissues other than bone to become hardened. When there is abnormal calcification of other tissues, such as muscle tissues, blood vessels, nervous tissues, it is called ectopic calcification. Other tissues that are not bone tissues have calcification inhibitors. So calcification inhibitors prevent the mineralization of collagen. However, when this ectopic calcification occurs, it is called sclerosis of some kind. So this can occur in lungs, this can occur in various parts of the body, this can occur in brain, muscles, tendons, arteries. So when it occurs in arteries, for example, it is called arteriosclerosis. So you do not want sclerosis or mineralization of any other tissue other than bone tissue. Now, we talked about how mineralization occurs. Now we're going to look at how reabsorption occurs. So reabsorption is when the opposite process occurs. It is the dissolving of bone. So when you have putting down of new bone tissue, you have to have at an equal rate the dissolving of old bone tissue as well. Remember, when this balance goes out of whack, you have disease of some kind. So reabsorption has to occur at a somewhat equal rate as well. And osteoblasts are the cells that produce new collagen. Osteoclasts are the cells that reabsorb. And here is how it occurs. So osteoclasts are macrophages. They're the ones that are going to phagocytosize. So these osteoclasts that have the ruffled borders are going to eat up the old bone tissue. So they have in their plasma membrane hydrogen pumps. So these hydrogen pumps are going to pump out hydrogen ions. Now in the extracellular space, so imagine the extracellular space, imagine the plasma membrane, these osteoclasts are going to pump out hydrogen ions. And in the extracellular space, you have chloride ions. So hydrogen ions plus chloride ions, H plus ions plus chloride ions is going to make HCl. HCl is nothing but hydrochloric acid. It's got the pH of 4, which is pretty acidic. Now hydrochloric acid dissolves bone. So it's chipping away at this mineralized bone, right? So it's dissolving it, eating away at the bone. Now all you have left to dissolve is these tough collagen fibers. These osteoclasts are also producing proteolytic enzymes. these proteolytic enzymes are dissolving these collagen fibers. So that is how bone is reabsorbed. Calcium and phosphate are two extremely important minerals for bone tissue. So phosphate is a component of DNA and RNA and ATP. So DNA is deoxyribose nucleic acid. It's got those phosphate backbones. ATP is adenosine triphosphate. You have about 0.75 kilograms of phosphate in the adult skeleton. Calcium is needed. Calcium is extremely important. Phosphate doesn't affect physiology as much, but calcium affects neural function. It affects muscle contraction, blood clotting, as we're going to see in the next few slides. So we have over 1 kilogram of calcium in the adult skeleton. So like I said before, phosphate levels have little effect physiologically, but changes in calcium can have serious effects. And we're going to look at what happens when we have less than normal calcium levels and when we have more than normal calcium levels. So first, let's look at hypocalcemia. Anytime you have the word hypo, it means less than normal levels. So hypocalcemia is the deficiency of blood calcium. First, calcium is one of the ions that is necessary for muscle contraction. So when you have less than normal blood calcium, what would that mean? So that would mean that your muscles are not able to contract or not able to relax. Sorry, they're not able to relax normally. So they're in a permanent state of stiffness. So when your muscles are too stiff, you're more prone to spasms, tremors, cramps, that sort of thing. So when you have less than normal calcium levels in your blood, aka hypocalcemia, it can cause something called tetany, is when your muscles become very stiff. So that can cause something called carpal tunnel syndrome, where when your wrists become very stiff. It can cause tremors, it can cause tetany. And so here's what happens. When you have less calcium, the sodium ion channels in your muscle tissue, and we're going to talk more about this in our next unit, which is the muscles unit, open up more easily, and your muscles remain contracted. So it gives your muscles the inability to relax. Your muscles cannot relax. And the causes of this can be calcium deficiency, it can be vitamin D deficiency, it can be pregnancy as well, because when you're pregnant, you're more prone to having cramps in your legs. The opposite of this is hypercalcemia. And this is extremely rare and potentially more dangerous than hypocalcemia. Hypercalcemia is excess blood calcium. Now, when you have more than normal calcium levels in your blood, your muscles are extremely relaxed. When your muscles are extremely relaxed, your reflexes are not normal. You have low muscle tone, and this can have very serious implications when it comes to the cardiac muscle, because you do not want your cardiac muscle to become too relaxed, because when your cardiac muscle becomes too relaxed, it stops, and that is what cardiac arrest is. So that is when the sodium ion channels are less likely to open and your muscle becomes way too relaxed, means it doesn't even function. So this is what causes cardiac arrest. So it's extremely rare, and that is what hypercalcemia is. Now we've seen what happens when you have too much calcium versus when you have too little calcium. But what is it that causes homeostasis? What maintains normal levels of calcium and phosphate in your bloodstream? Now remember, the reservoir for calcium and phosphate is bones. So when you need more calcium in your bloodstream, where is it coming from? Your bone. When you need more phosphate in your bloodstream or less phosphate in your bloodstream, it is coming or going from your bone. And this is played out by three hormones. These three hormones are listed right here. The first one is commonly known as vitamin D, also known as calcitriol. The second one is known as calcitonin, and the third one is the parathyroid hormone. Two of these, calcitriol and calcitonin, we're actually going to look at the mechanism of all three of them. So let's go to the first one, which is calcitriol. Now, calcitriol raises blood calcium. So calcium is, so stay with me here. I'm going to go a little bit slower here. So calcitriol raises blood calcium. So calcium is stored in your bone, right? So something happens and your body decides blood calcium level is getting a little low. I need to get into my reservoir and I need calcium. Calcitriol is going to make that happen. So what calcitriol does is it increases intestinal absorption of calcium. So you're eating foods, calcitriol is going to decide that I'm going to increase the absorption of calcium from whatever you're eating. It increases reabsorption from the skeleton. So it's going to say, hey osteoclast, take more calcium out of my bone. So it increases osteoclast production and it increases osteoclast activity. And it is also going to increase absorption of calcium from the urine. Now, say for some reason your body is not making enough calcitriol, aka vitamin D. You're deficient on vitamin D. What does that cause? It causes your bones to become soft. So when bones become soft, they bend, and that causes misshapen bones. So in children, it's called rickets and osteomalacia in adults. So here you can see it not only affects human beings, but also animals. So here you can see a goat with the misshapen bone right here, and that's rickets or osteomalacia. Now, the human body can synthesize, in ideal conditions, the human body can synthesize its own calcitriol, aka vitamin D. But if we live in cold parts of the world where we're not exposed to sunlight, people require supplements of vitamin D. And the body synthesizes vitamin D in a few steps. So make sure you know these steps. Understand how the body produces these steps. You don't have to know the structures, the chemical structures of these, but understand how the body produces this. And your integumentary system plays a critical role in this. So here's what happens. You go sit out and expose yourself to sunlight without wearing sunscreen, because UV radiation has to penetrate the keratinocytes of your skin. The more melanin you have, the less likely you are to produce your own vitamin D. The less melanin you have, the more likely you are to produce your own vitamin D. So here's what happens. The UV radiation from the sun hits your keratinocytes. Where are the keratinocytes present? They're present in your epidermis. Now, in the keratinocytes, in the plasma membrane of the keratinocytes, you have cholesterol in the plasma membrane. Now, as the UV radiation hits the cholesterol is converted to something called cholecalciferol. So in the first step, UV radiation converts cholesterol to cholecalciferol. Now this cholecalciferol ends up in the liver. Cholecalciferol goes to the liver and is converted to calcidiol. Now this calcidiol goes to the kidneys and gets converted from calcidiol to calcitriol. So you have a few different organs that are playing their roles here. You have the skin or the integument, then you have the liver, and you have the kidney. So let's recap this step. UV radiation hits the keratinocyte, converts cholesterol to cholecalciferol. Cholecalciferol goes to the liver, gets converted to calcidiol. Calcidiol goes to the kidney, gets converted to calcitriol. And calcitriol is then going to increase osteoclast activity, is going to increase absorption of calcium from your food, it's going to increase absorption of calcium ions from your urine as well. And therefore, it is going to increase your blood calcium levels. Now, the next hormone that is also going to raise calcium level in your blood is the parathyroid hormone. It is secreted, parathyroid hormone is secreted from the parathyroid gland, which is located on the posterior or the dorsal surface, or from the parathyroid gland, which is located on the posterior surface of the thyroid. Now, it also raises the blood calcium level by stimulating osteoclast. So when osteoclast is stimulated, it is chipping away at your bone, and when bone is chipped away, you have more calcium ions that are floating around in your bloodstream. It also inhibits osteoblasts. So it's inhibiting building of new bone. When new bone building is inhibited, it's preventing building of the reservoir. So when the reservoir building is inhibited, it means you have more ions that are floating around in your bloodstream. So it is also promoting the absorption of calcium ions by the kidneys, and it's also helping making of vitamin D. So that is what it's doing to promote making of your blood calcium levels stable. Now, I like this circuit chart because it explains the calcium homeostasis really well. So something happens, for example, let's say that something is pregnancy. Something happens and homeostasis is disrupted. So homeostasis is disrupted and it decreases blood calcium levels. So in this case, the fetus is sucking up all the calcium levels. So blood calcium levels in the mother are decreasing. The mother's blood calcium levels have to be raised. So these receptors in this case are the gland cells, or the parathyroid gland cells. They have detected that the calcium ions are low. So these detectors have detected that the calcium ions are low. Now what has to happen? The parathyroid gene gets turned on. Something has to happen. What is that something? Something has to happen, and that something is that calcium ions have to be increased. Now these effectors in that case is osteoclasts increase bone reabsorption. Kidneys start to excrete or absorb more calcium ions, and hence calcium level is increased in the bloodstream, and calcium ends up returning to normal. Now the next hormone does the opposite. Now something has to be able to decrease blood calcium levels too if there is too much calcium. Now calcitonin decreases blood calcium levels because hypercalcemia is also bad. Now calcitonin reduces osteoclast activity and increases osteoblast activity. Now this is secreted from the thyroid gland. This is important in children but has very little effect in adults, as hypercalcemia is extremely rare. So this chart explains what's going on. So let's start with this diagram on the left. So calcium intake, the dietary requirement is about 1 gram or 1,000 milligrams per day as a dietary supplement. So you can get this as a calcium pill, or you can eat foods that are rich in calcium like milk. So you take this orally, and about 350 milligrams is lost fecally per day. About 650 milligrams is lost via urine per day. Now, the digestive tract absorbs calcium with the help of calcitriol, aka vitamin D. The kidneys absorb calcium as well, with the effect of calcitriol as well as the parathyroid hormone. Now, when it is absorbed by the digestive tract, it is floating around in the bloodstream. It is also floating around in the bloodstream when it is absorbed by the kidneys. Now, once it reaches normal blood levels, it is deposited onto the bones by calcitonin and the osteoblasts, which are the bone depositing cells, directly onto the bone. When the blood calcium level gets low, osteoclasts, which are the bone chipping away cells, bring the blood calcium levels back up, along with the calcitriol and the parathyroid hormone, with the help of the bone chipping cells, which are the osteoclasts. So I hope everyone understands how these cells and the hormones are kind of all putting the different pieces of the puzzle together to form this big picture. Now, the next concept we're going to go to is bone fractures and how aging affects the skeletal system. Now, bones are prone to injuries and fractures. Fractures are named by the cause as well as how the fracture occurs. A stress fracture is caused by trauma, and a pathological fracture occurs by the bone weakened by disease, such as bone cancer or osteoporosis. A stress fracture can occur in an otherwise healthy bone. A fracture can also be named by anatomical characteristics based on how many pieces the bone has broken into, whether the bone has broken the skin, and so on. Healing of fractures is a long process and depends on age as well. Fractures heal quicker in children as opposed to the elderly, and they typically take place in 4 steps. In the first step, a hematoma forms. A hematoma is clotting of blood under the surface of the skin, and it happens about 6 to 8 hours after an injury. So you see over here that the blood vessels have broken underneath the surface of the skin, and the blood has pooled right here from the broken vasculature. So phagocytes remove all the cellular debris right here, and a bruise forms. In step 2, fibrocartilage, or formation of a soft callus, takes place, and chondrocytes from the periosteum around the bone form a soft cartilage of protection around a bone that is going to take much, much longer for it to heal. In step 3, a hard callus starts to form. So you see right here, at these places, a hard bone is starting to form. And this process takes about 3 to 4 months, faster in younger children. And trabeculae are starting to form as well. So first, it is the spongy bone that is going to form, and later it is the compact bone that is going to form. In the last step, the bone remodeling takes place, and the debris is eaten up by the osteoclast, and spongy bone is replaced by compact bone. As people age, the level of sex hormones that a person produces decreases, so there is decrease in bone mass. The amount of osteoclast activity exceeds the amount of osteoblast activity, and this affects females more than it does in males, because hormone loss occurs more in females after menopause. So after menopause, there is more bone loss in females. So there are 2 principal effects of aging on bones. One is bone loss, so where there is loss of calcium from bones. And that happens because there's loss of calcium. So this is when there's more bone reabsorption than there's more bone production. The second is brittle bones. Now, brittle bones is because there's not enough collagen production. So this is when bones become very susceptible to fractures. So extensive loss of bone mass and brittleness, that's called osteoporosis. So after menopause, females are very prone to osteoporosis. So here's scanning electron micrographs. To the left is a scanning electron micrograph of a normal bone. You can clearly see, this is a scanning electron micrograph of a spongy bone where you can see the trabeculae. And to the right is a scanning electron micrograph of a osteoporotic bone. So by age 70, average bone loss is about 30%. And it typically affects the wrists and the vertebral column the most. Now, in both sexes, the hormone estrogen maintains bone density. And in men, the adrenal glands and the testes produce estrogen, whereas in women, the ovaries produce estrogen during egg development. However, after menopause, estrogen production does not happen as much as during ovulation. Now, hence, there's no estrogen and there's rapid bone loss. However, there are several drugs available for treatment. Now, the common drugs are anti-reabsorptive drugs, which significantly slow progression of osteoporosis. The common drugs are bisphosphates and selective estrogen replacement drugs. So the estrogen replacement drugs mimic estrogens, and the bisphosphates inhibit osteoclast activities. So they prevent osteoclasts from chipping away at the bone. So therefore they prevent bone loss from happening.